Good evening, everyone. A warm welcome to all of you who have joined us for this special session on the topic What Doctors Ask Mostly Clinical FAQs on Thalassemia. I am Arpita from the IGCP group, and it is my absolute honor to welcome our host for today's session, none other than Dr. Sharda Jain ma'am, who has an extensive teaching background in obstetrics and gynecology. She has contributed to the training of numerous medical professionals. She served as the Secretary General of the Delhi Gynecologist Forum and is the chairman of the North India Gynecologist Forum. She is an expert on the ethical committee of the NMC for the last 6 years. So with this very brief introduction of ma'am, I would now request her to please start with the session. Over to you, ma'am.
Thank you, Arpita, for giving us this platform. I'm joined with the two great stalwarts of Delhi Gynecologist Forum, Dr. Leena Sridhar. She has been earlier in the army and now she is the head of the Department of Manipal Obstetric and Gynecology Department. And she's also the chairman, she's also the president of DGF Dwarka. Another expert and the stalwart is Dr. Deepthi Naab. She is also the president of the Delhi Gynecologist Forum East. And these two people will be the experts. At the end of my talk, they will be making comments. So over to you, Dr. Leena Sridhar.
Good evening, ma'am, and good evening to all the viewers. It is truly an honor to introduce today's esteemed speaker, Dr. Sharda Jain, ma'am. She is a highly respected leader and a mentor in the field of obstetrics and gynecology. Her commitment to women's health is evident throughout her leadership in founding the North India Gynecologist Forum and many national initiatives such as the Female Feticide, Anemia Mukt Bharat, Movement Against Anemia, the Janani Suraksha Yojana, and the cervical cancer awareness campaigns. In a recognition of her contributions, she has been honored with numerous lifetime achievement awards from prestigious bodies including FOXI, ICOG, Delhi ISAR, and the Lady Hardinge Medical College, among so many others. Dr. Sharda Jain, ma'am, she is a true trailblazer whose work continues to inspire and uplift the medical community. We are deeply privileged to have her here today on the eve of the Thalassemia Day. So she's here to talk about the Thalassemia mission and the common questions and answers which doctors face in relation with thalassemia. Over to you, ma'am.
Thank you very much. Malti, can I have my presentation, please? My presentation?
Ma'am, it is visible on the screen.
Okay. Yes. I think Thalassemia mission is a very special mission for Delhi Gynecologist Forum because we feel that thalassemia is something to be noticed about. It's a big public health problem. And you will be surprised to know that 10,000 thalassemia major babies are born every year. And I think, this is something which is not acceptable to the civilized society. Can I have the next slide? Tomorrow is the Thalassemia Day, and my presentation will be in a frequently asked question and answer. Next one. Next one. Next one, Malti, yes. Now coming to the screening and prevention. It is said, next one, it is said that the screening of thalassemia is very necessary in India because you can find in today's time, thalassemia major people are 1 lakh and sickle cell are 1.5 lakh. And because of not screening all people, 10,000 new thalassemia major births are born annually. In the city of Delhi, you find 30% couples do not only undergo screening, and the 70% couples don't go and undergo screening during pregnancy. And this is failure to identify carrier couples results in a preventable birth of affected children. Next one. Now, what is the gold standard of thalassemia screening? The gold standard test for thalassemia screening is HPLC, that is high performance liquid chromatography. It is a gold standard, and it is detecting minor, intermediate, and major forms of thalassemia accurately. Next one. Now, at what point the thalassemia screening need to be offered? Pre-marriage, preconception, or as early in the first trimester before the fetal organogenesis, it is complete. It should be done because it allows, for a couple to make reproductive choices. Next one. All patients who are thalassemia patients should be J.S. Arora is the Secretary General of Thalassemia Society of India, and according to him, the children must be right in the school before admission. When they get their blood group done, they should get a thalassemia screening done. And this is what feels that in a pregnant patient, should be universal, that not a single patient should be left out without screening for thalassemia. Next one. If the mother is negative for thalassemia minor, is paternal screening necessary? Normally, the answer is no. If the mother is negative, the paternal screening is not mandatory. But I have a different viewpoint. If the gentleman, it is an opportunist screening. If the gentleman happens to be thalassemia minor and the mother is thalassemia major, still there is a 50% chance that 50% children will be thalassemia minor, just like the father. Next one. If the mother is positive for thalassemia minor, what next? The paternal screening must be done immediately. If both parents are carriers, prenatal diagnosis, which is normally done in the form of Cordon villus biopsy, can be done at 11 to 12 weeks, and that's advised. Next one. What happens if both partners are thalassemia minor? This is a bad situation. There is a 25% chance of having a thalassemia major child in every pregnancy. Prenatal diagnosis is critical. Next one. You find that, I missed out the picture here because, there'd be some glitch here. So the presentation has not gone correctly. But you can find that in case if the mother is thalassemia minor and the father is absolutely normal, then 50% children will have thalassemia minor and they will lead a normal life unless their hemoglobin drops less than 8 grams per cent. But if both the couple are thalassemia minor, then there is a 25% chance of a child being born with thalassemia major. 50% chance is there for child to be born with thalassemia minor, and 25% children will be absolutely normal. Now, question is how effective? How effective is prenatal diagnosis in preventing thalassemia major? I will say that it is 100% effective if screening is done timely and the couples are counseled correctly. Next one. Can thalassemia be cured after birth? Currently, only bone marrow transplant can cure. And it is expensive in our country because donors have to be HLA matched. So only 10 to 15% find eligible donors, and then the matching is done, it is done. Out of 18,000 cases which have had a bone marrow transplant in the last 45 years, only 4,500 cases have been done for thalassemia major. The other alternative which has come is that people get their child's, if you find one of your child is thalassemia major, then you can plan another pregnancy and the stem cells can be stored. And if that particular child happens to be normal, these stem cells of the child can be used for the elder child. And you find only 10-15 cases have been done in this particular country, but they have been absolutely successful. So this is what the limitation is. Public awareness about this thing is not very much there. And now, since the time the government has banned that no culturing can be done from the cord cell stem cells, it is very unfortunate that things cannot be done. The only choice is left with the people is that they will have a bone marrow transplant from the donor, which has to be HLA matched. And that's why you find 10 to 15% eligible patient only get the matched bone marrow transplant. Next one. Management of thalassemia minor and intermediate, what should be done? Next one. Patient who has got thalassemia minor, or they're said to be, they have a carrier of thalassemia. Thalassemia minor individuals are usually asymptomatic, but may have mild anemia. No treatment is required, but genetic counseling is essential for reproductive planning to prevent major births. Next one. Now, how is thalassemia intermediate different from thalassemia minor and major? Many of the gynecologists are not aware there is a term like thalassemia intermediate. The patients have a moderate anemia, may need occasional transfusions, but do not require regular lifelong transfusions like thalassemia major patients. Early diagnosis help in proper monitoring and reducing complications. Next one. What are common hematological findings in thalassemia minor? These are microcytic hypochromic anemia they have with the normal iron studies and elevated HbA2, which is more than 3.5 on HPLC. Next one. Why should thalassemia minor not be misdiagnosed as iron deficiency anemia? Both present with microcytic anemia. If treated wrongly with iron in thalassemia minor cases, it leads to iron overload without benefit. Here, I just wish to tell you that if you find that the iron store is less, you can give these patients 1 capsule of iron folic acid. But you can't load like other patients with 2 tablets or 3 tablets. HPLC testing differentiates the two. Next one. Can 2 thalassemia, and here I just wish to tell you there is a Mensa score, and in case if the score is less than 13, which can be, one can evaluate on CBC. If it is less than 13, then it is thalassemia minor. If it is more than 13, it is iron deficiency anemia. Can 2 thalassemia minor individuals marry? They can, but only after understanding that 25% risk they have that affected child will be having a thalassemia major. 50% chance is there that children born will be thalassemia minor, just like individual couple. And only 25% will be absolutely normal. Prenatal diagnosis is compulsory in such patients whenever they plan pregnancy. Next one. What is the role of pre-implantation genetic diagnosis in thalassemia prevention? The couples at risk can undergo IVF with PGD to select embryos free from thalassemia major, avoiding affected pregnancy. But these patients, normally you find that they readily conceive, and that's why they do not require IVF with PGD. And they can have a prenatal diagnosis, whether the baby is normal or thalassemia major at 11 or 12 weeks of pregnancy. Next one. Is there a safe window for prenatal testing for thalassemia? Here I just wish to tell you that the gynecologists can do chorionic villus sampling, that is CVS, between 11 to 13 weeks or amniocentesis at 16 to 18 weeks. Invariably, the job is done with chorion villus biopsy if the patient comes at time. Amniocentesis is invariably not required in our practice. Early diagnosis allows safer and less traumatic decisions. Next one. How do you counsel a couple where both partners are thalassemia minor? I think, gynecologists need to counsel these people. A full genetic counseling also need to be done in such patients. Explain the risk of affected child. Prenatal diagnosis is the option, which is chorion villus biopsy at 11 to 12 weeks and amniocentesis later. And possibility of PGD IVF also need to be told people who find difficulty in conceiving the child. Next one. What emotional aspects should gynecologists address in a carrier couples? It is fear, guilt, stigma, decision anxiety are common. Non-judgmental counseling with family support is critical. All gynecologists who are listening me, they must have found one or two or more couples where both the couples were thalassemia minor. And as things happen with them, that when they get a prenatal genital counseling done at 11 to 13 weeks, one after another, the babies are thalassemia minor. In such patients, you have to give them a lot of emotional counseling. I've had 3-4 patients of mine where in one go they did not get the normal child. They had to go through 2 or 3 pregnancies each time before they got the normal child. So it is you have to see that you have to handle these patients very emotionally and then allay their anxiety. And non-judgmental counseling with the family support is very, very critical in such patients. Next one. What if only one partner is thalassemia minor? No increased risk of thalassemia major is there in the child. Routine antenatal care continues. Here I just wish to tell you that the people who are thalassemia intermediate, these are the people where hemoglobin drops below 8. There the hematologists recommend that they should have blood transfusion. Next one. Now, as far as the medico-legal aspect is concerned, if the gynecologist is not aware about it, that such kind of screening has to be done. And if she fails to do that kind of things, the medical-legal issues of medical negligence will crop up tomorrow, because once the couple comes to know this could have been done very easily in pregnancy, right in the first trimester, and it was not done in your case, then it calls for a medical litigation will be there against you. So always document counseling and refusal, if any. You have to do it both in writing. You have to take a refusal that they did not want to get undergo these kind of testing. Next one. Should counseling be verbal or written? Here again, with the point which I just wanted to make to you again, both are needed. Written information and a signed informed consent will protect the doctor legally. Next one. Next one, Malti. Can late diagnosis of thalassemia major lead to legal action? Yes. If the parents are not offered screening and a thalassemia major child is born, compensation lawsuits can occur. There are multiple such cases have been there. In fact, I came to know about 10, 12 years. There are 300 families which have got settled after partition in Lucknow. And the gynecologist, not knowing about this, they had litigations one after another. So that's why I wish to tell you that they need to know, and they must screen each and every pregnant patients for thalassemia minor, thalassemia intermediate. Next one. How often should a thalassemia minor individual to be monitored? If they're asymptomatic, no specific monitoring is required. Just like a routine antenatal checkup, but routine CBC during health checkup is important. Right at the beginning, again at 20 weeks, they should have a CBC, and close to 35, 34 weeks, they should have again a CBC. If any times the hemoglobin drops below 8 grams %, with the help of hematologist, if he feels that she requires a blood transfusion, that need to be given. Next one. Does thalassemia minor affect pregnancy outcome? Generally, no. Minor carriers have a normal pregnancies, but iron overload given inadvertently by the gynecologist should be avoided. They can have 1 capsule of iron folic acid. That's it. Next one. What is the role of gynecologists in thalassemia prevention? Gynecologists have a great role. They are the first contact. Responsibility lies in the gynecologist in screening, counseling, documentation, and referral when needed. Next one. Can thalassemia minor individuals donate blood? Yes. If the hemoglobin is normal, they can donate blood. However, they must let the other people who's receiving it know that you are thalassemia minor. Now, what are the myths about thalassemia that need? How can a community awareness be increased? Community awareness should be increased through the awareness program right in the school and the colleges. Marriage counseling, seminars should be held in the community. Antenatal camps should be done, and it should be made mandatory. Health checkup packages should be there. So every individual who comes with a pregnancy should know their thalassemia status. Next one. What are the myths about thalassemia that needs to be busted? One myth is the carriers are sick. No, the carriers are healthy, but they can pass on the gene. Only certain communities have it. Now we know it. Previously, we also used to think that certain communities only have it. But now we know it's a widespread across all regions in the community. Because there is no registry, the mapping of things are not complete at all. It is very patchy. Like in Maharashtra, it is said that the incidence of thalassemia trait is found to be anything between 6 to 9%, while in Gujarat, it varies anything from 3 to 6.5%. So it all depends upon, where you are there, but widespread across all regions, the thalassemia cases are noted. Next one. What is Delhi Gynecologist Forum's pledge regarding thalassemia? This is our mission, that every pregnancy need to be screened for thalassemia, every carrier should be counseled, and every child need to be protected. Together, we will make the Delhi model for a thalassemia-free Bharat. Next one. Call to action is that every gynecologist's duty it is offer thalassemia screening as a standard of care, counsel every carrier couple, prevent every thalassemia major birth. If the Delhi will lead, Bharat will win. Next one. Hello. Now, here I just मालती इसको बंद कर दे बेटा. Here I just wish to tell you that there is a German NGO who is doing its activity in many countries. It is doing its activity in India also. And here the donors come forward. Outside you can find that, 50 to 60,000 donors are there. In contrast, in India, such a big country, and we find the donors on the list are something like 8,000. And it is 4,500 cases of bone marrow transplant have been done. It is because of the help of these donors. So I think, such activities of awareness should be there, and more volunteers should join. In fact, we should request the government also that stem cell, cord stem cell banking should be encouraged, but they should be allowed. There's no point getting this cord stem cell banking done in case if the government does not allow them to be cultured, because the amount of stem cells which are available in the cord, I think it need to be multiplied before they can be used. Now, certain bodies have started doing a public stem cell collection. So anybody who has got a thalassemia major child can get those stem cells, because it is said that the cord stem cells do not have any kind of immunization problem with such cases, and such samples can be collected. But I think public awareness, more and more public awareness is needed. I'm sorry, my presentation is changed in the last bit, and there had been Thalassemia Society has made many slogans, which I think every couple should know, every school should know, every college should know, that things are simple. You must screen yourself for thalassemia, and you should try to see that you do not marry another thalassemia minor patient. But in case if you marry, if two persons are thalassemia minor, in that particular case, they should have a thorough counseling time and again, so their facts are very clear that 25% children born by them will be thalassemia major. And these are the patients who require every 2 to 3 weeks blood transfusion. It is said that thousands and thousands of packed cell blood is needed to take care of 1 lakh thalassemia major patients in this country. So I think with these remarks, I will leave our experts to make comments, Dr. Deepti Nab and Dr. Leena Sridhar.
Thank you so much, ma'am. Wonderful presentation. And I think very rightly you have said this is just a simple test, HPLC, high performance liquid chromatography, a simple test to identify individuals with thalassemia. Now, we should be aware of certain myths. It is an inherited blood disorder. It is a quantitative globinopathy, wherein the globin part of the hemoglobin is either not formed at all, that there is zero formation, or there is a reduced formation. So depending upon, the severity depends upon the kind of gene mutation or the number of genes mutated. And so accordingly, one can have thalassemia minor, thalassemia major, and also thalassemia intermedia. Now, this is the tricky part because individuals with thalassemia minor and thalassemia intermedia will not have very significant clinical symptoms. They may just have minor fatigue, anemia, weakness, and only once the blood test is done, when you're aware that there is an entity called thalassemia, you get the test done, and then you get to know that the individual is having thalassemia minor or intermediate. Major, of course, this is diagnosed right after birth, a few days or weeks after birth. So I think that it is mandatory, it is imperative on our part to incorporate thalassemia screening into routine antenatal screening so as to have a better fetal maternal outcome. Birth of a thalassemia major baby is a great emotional stress, a financial burden, not only on the family, the society at large, the entire health system of the country is affected. And just a simple test is enough to make us aware that this baby is going to be thalassemia major. And the another myth is that if the family has got no history, there is no need for this screening, or only out of the couple, only the girl needs to get her thalassemia screening done. No. Because again, I would repeat what ma'am had said, that individuals with thalassemia minor and intermediate both could be absolutely asymptomatic. And there is where we make a grave mistake of taking your young and healthy, you could not have thalassemia. No. Incorporate it in your prescription. The list of checks which are done when she comes to you for the very first counseling, along with the blood group, please write HPLC. In fact, now that we have so many couples who are aware and come to us for pre-pregnancy counseling, they also must get their HPLC done. Pre-marriage, the parents, the society has to be taught that instead of getting the Janampatris evaluated for kitne grah milte hain, get a HPLC screening done. The patient, the couple, if getting married, they can make informed reproductive choices that, okay, you get married, 25% chance of a thalassemia major if both of you are minor, and 50% chance of a baby with thalassemia minor. So you can decide whether you still want to have a baby. You can have an early prenatal testing done, or you can go for an IVF with PGD and get only those embryos transferred who are thalassemia negative. And just a counseling is enough to make us aware. So it becomes our duty to see that we have a society where soon there is not even a single thalassemia major baby born. With that, I would pass on to ma'am again.
Thank you. I mean, that was such a wonderful presentation. I'm completely mesmerized, and I think we have touched on all the aspects. Ma'am has explained it so beautifully and so simply. What is very clear in what my co-expert has just commented. Recently, I had a couple who had a first thalassemia major baby, and sadly enough, no testing had been done in that first pregnancy. Fortunately, they were able to get a bone marrow transplant, and that first child is perfectly healthy. She took 6 years to conceive the next time because they were so scared And of course, this time she had come to me, and we have done the screening, we have done the testing, and it was an absolutely healthy baby. And so that therefore underlines the very great importance of screening, both pre-marriage, pre-conception, and most important, because the patients come to us in the first trimester. So therein lies the important role of gynecologists to do the screening in the first trimester. So the message is very clear that all pregnant women have to be screened. It is our duty. It's most important. We are medico-legal liable to screen our patients in case we miss a thalassemia patient. Like very correctly pointed out, it amounts to negligence. So this is very important thing, and it is to be remembered. And nowadays we have all the tests. We have CVS, which can be done in the end of the NT-NB scan, that is 11 to 12 weeks. And there is actually that is such a simple way of being able to screen in case both the couple, the husband and wife, both are thalassemia minor. An important thing is that if only the lady is thalassemia minor, many times you find that they are extremely worried. So we need to counsel them. We need to tell them that, look, apart from anemia, you're going to be healthy. You're going to have a healthy baby, and it's important that we keep your, your hemoglobin all right. And sure enough, if we can do that, she should be able to have a completely normal pregnancy and a delivery. Very important to understand that apart from thalassemia minor and thalassemia major, we have a thalassemia intermedia. So we have to be very careful in bringing in an early diagnosis. The HPLC, as rightly pointed out, is the most accurate test, and it is available, and it should be taken there. And in many other cases, we can have a very strong suspicion when we get just a simple complete blood count done, or we get a peripheral smear. Even that can give us a suspicion, and it can guide us to getting an HPLC done in case we are not able to do it for all patients. But it is to be remembered that a thalassemia screen now in today's times should be offered to each and every patient, and we should document that we have counseled them in case they don't want to undergo this test. So that's very important. Our notes must mention that we have counseled them for this test. And so this is very important, and we as gynecologists must take the lead in making Delhi free of thalassemia babies. And obviously, as the Rajdhani, if we take the lead, then definitely Bharat will win the war against thalassemia. Ma'am, we can't hear you.
The slogans are in front of me. The test before tying the knot, before you get married, I think the testing must be done, and it will save future generation from thalassemia. And thalassemia, as you all know, is a totally preventable disease. Birth of a thalassemia child is a totally preventable disease. One test can save the life. And be aware, get tested. So say no to thalassemia major. Zero thalassemia birth is our mission and our responsibility. Carrier today, do not regret. Tomorrow, get a thalassemia test done. Now, here I just wish to tell you that some people may like to know how the bone marrow transplant is done. If you happen to be donor, they only take one test from your saliva से एक आपका test लेते हैं जिससे कि वो HLA matching करते हैं. So they have a pool. This organization has a pool of people who are donors, and whenever the matching is done, the sample has to be done. Again, nothing to get scared about it. Before you give the bone marrow, 5 दिन पहले आपको इंजेक्शन लेना पड़ता है. ये इंजेक्शन इसलिए दिए जा रहे हैं कि आपका बोन मैरो प्रोडक्शन ऑफ स्टेम सेल्स बढ़ जाए. एंड देन बहुत लोगों ने कोविड के टाइम देखा होगा कि वो एक हाथ से आपका सैंपल निकालते हैं. इट गोज थ्रू मशीन, and then whatever the number of stem cells they want to take it away from there, from other side it just goes back. It is a very simple thing. It just takes neat 10 minutes for under professionals to do it. इसको जो donor है उसको भी कोई परेशान होने की जरूरत नहीं है, और जिसको मिलता है वो तो it's a professional work. And now you find you don't have to go to Europe to get the bone marrow transplant done. It is very much available in this particular country, though it is a bit expensive. But I'm sure when you see the thalassemia major child having a blood transfusion every month, then you definitely feel it is worthwhile to spend that kind of a money. So I think, all of us have to see that thalassemia awareness has to be created, and there should not be any birth of thalassemia major child. I again repeat, we have 1 lakh cases of thalassemia major in the country today, and 10,000 cases of thalassemia major are added every year. So that should be taken care. If there are any question, Arpita, we can take.
Yes, ma'am.
Yes.
Yes, ma'am. I'm putting the questions in the chat. Will that be okay, ma'am, or shall I read them out?
You read them out, because I can't see. Leena and Deepti can see and they can answer.
Okay, ma'am. I'm reading them out, ma'am. Ma'am, the first question is already answered. It was, should HB electrophoresis be done in all antenatal cases, where Dr. Deepti has written yes, Dr.
Yes.
Leena has also written yes. Okay. The next question is from Dr. Kalpana. She wants to know, every pregnant lady should be tested for thalassemia.
Yes, of course.
Yes.
Definitely.
Okay.
That is the aim of this ma'am's presentation today.
I'm requesting to all Delhi gynecologists, 30% cases only have screening done. In 70% cases, the pregnant lady is not screened. It is our request of all 3 experts with the folded hands, please do it. Please do it.
Okay.
Next one, Arpita.
Next is from Dr. Neelam Gaur. When to screen for thalassemia?
When to?
When to screen for thalassemia?
J.S. Arora says that before the child is admitted in school, right with the blood group, thalassemia testing should be done. Because otherwise, the child must be ingrained in that particular child that you are a thalassemia minor. You are absolutely all right, but you should not marry a thalassemia minor. And other time is before marriage, before conception, and during the first trimester itself, before the organogenesis, right in the beginning itself, she should get screened for thalassemia.
Right,
simple blood test.
And ma'am, if both patients have thalassemia minor, what is the recommended protocol for fetal diagnosis and counseling?
Dr. Deepti, want to take it? Dr.
Yes,
Deepti?
Yes, ma'am. So if both the partners, the couple is having thalassemia minor, and the patient, the girl has come already pregnant, she's already pregnant, then the next choice is to advise her for a prenatal diagnosis, wherein a chorionic villus sampling is done between 11 to 13 weeks, and the confirmation is done for the fetus. But if she's come later, then we can still offer her amniocentesis, which is done around 16 to 19 weeks. Beyond that, seldom ever in Delhi will a girl come late. However, if she's come to you before she has become pregnant, in that case, she is counseled, that both husband and wife are counseled that you have a chance of having a baby with thalassemia major 25% and thalassemia minor 50%. So you can still go ahead with the pregnancy, but be aware of these facts. And it is only once you get pregnant that the test will be done at around 11 to 13 weeks, and the confirmation of the baby will be done, whether the baby is affected by thalassemia or not, and then further management will be carried out. So I repeat, if she's come already pregnant, that at 11 to 13 weeks or later, 16 weeks, an amniocentesis is done. But if she's not pregnant, she's come for pre-pregnancy counseling and both are thalassemia minor, then she is to be informed that these are the probabilities and how you can plan your pregnancy. Counseling, and information in detail.
Arpita, any more questions?
Yes, ma'am. There is one appreciation, that is Dr. Deepika. She has written, excellent webinar. Thanks, Dr. Sharda ma'am, Dr. Deepti, and Dr. Leena for this guidance. Thank you. Thank you so much, Deepika
I
ma'am.
just wish to share my personal experience with thalassemia minor, both the couples. I've had about a dozen patients like this. 10 of them have had a babies. Some people, first baby has been all right, and they found it was an easy game, and then second and third, you find they got it had to be terminated, and then they had a second child. But I know of a couple, two engineer couple. It was a love marriage from them. They went through 3 pregnancies, and every time it was thalassemia major child. So finally, they adopted a child. Another patient also, they were not that educated as a businessman. Again, 3-4 times, they tried and they could not have a normal child. It was not a normal child, or thalassemia minor is also okay, but thalassemia major is not acceptable. So out of this over dozen cases, we've had 2 cases where they could not have the child. Every time the ill luck was there with them. Thank you so much.
And there are
Thank
one
you.
or two more queries.
Hello? Yes,
Yeah, ma'am,
please,
can we take
go ahead.
one or two more queries? Okay. Ma'am, what is
Please.
the current role of genetic counseling and partner testing in thalassemia prevention strategies in India?
Dr. Leena, you want to take it up?
Yes, ma'am. So, can you repeat that question, because it wasn't very clear?
Yes, ma'am, I'm reading it out. What is the current role of genetic counseling and partner testing in thalassemia prevention strategies in India?
Yeah, so just like we have just discussed, when we have to do routine HPLC testing for our patients. And if you find your patient is thalassemia minor, it is mandatory that the partner is tested for the thalassemia gene. That's very important. And so they have to be very clearly told that if only the one is thalassemia minor, the other is normal, she's likely to have a normal pregnancy, and the only big challenge will be to keep her hemoglobin under the normal levels till she delivers. Then if both turn out to be thalassemia minor, then there is almost a 25% chance that the baby is likely to be thalassemia major. That is grave. So therefore these patients will be offered the appropriate testing, that is the chorion-Willis sampling between 11 to 13 weeks of pregnancy. And should they miss that window period, then they can be offered an amniocentesis between 16 to 19 weeks, so that appropriately it is picked up whether they are carrying the thalassemia major baby, and then appropriate termination can be done. So this is what we are following, and this is what is going to be offered to the patients.
Thank you, ma'am. Thank you so much.
Arpita, any more?
Yes, ma'am. One last query. That is, what are the key differences between thalassemia minor and iron deficiency anemia during pregnancy, and how they can be differentiated clinically?
See, clinically, you can't differentiate. You have to get a CBC done. And in CBC, you find that if there's a Mensa score is there, if it is less than 13, then you suspect that this patient is thalassemia minor. If score is more than 13, it is iron deficiency anemia. In iron deficiency anemia, normally the stores of the iron are less or exhausted. While in thalassemia, you can find there is a good number of patients who maintain a normal iron stores. So that's why you can't overload thalassemia minor patients because if patient hemoglobin is 9 gram percent or 10 gram percent, it is said that, the government of India and guidelines are there for iron deficiency anemia, you should give an injectable iron. But in this particular patient, you've got to test for the stores. And if the stores are normal, then you can't give so much of iron to them, because that overload of iron is going to definitely harm them. So one can easily differentiate. Only thing one should be conscious that can be together. That iron deficiency anemia and thalassemia thalassemia minor have to be differentiated, and it's a very easy that you can differentiate it. Dr. Arpita, Dr. Leena, you want to share your personal experience, and Dr. Deepika, Deepti, you want to share your experience? Because
Yes,
if
ma'am.
you share, the stories remain with people.
Yes,
Yes,
ma'am.
ma'am.
I would like to share my experience from the very beginning of my career. This young couple is coming to me, and so that time awareness of HPLC was zero, unfortunately, and got a routine CBC done. Her hemoglobin was 11. As time passed by, she started complaining of feeling very tired, very tired. So, which generally take some supplements, ask the husband, help her at home. This continued till I got a hemoglobin run. That why she's repeatedly complaining of fatigue, backache, leg pain, and the hemoglobin had crashed from 11 to 8. Despite giving her doubling of the iron tablets, it remained at 8. And that is the first thing it struck me. My God, is she thalassemic? And by the time this thought came into my head, it was already, ma'am, around 18, 19 weeks. She was thalassemia minor. When the husband sees the report with me, he says, "Oh, ma'am, मेरी बहन भी thalassemia minor है." I still remember that particular moment, ma'am, and that day when he looks at the report along with me and he says, "हाँ मैम, ये तो मैंने देखा है, मेरी बहन भी thalassemia minor है." I said, "Why didn't you tell me?" He said, "You didn't ask me." That was the toughest lesson of my life. क्यों आपने मेरे को पूछा ही नहीं, तो मैंने आपको बताया ही नहीं. So, of course, he was also thalassemia minor. The child was born thalassemia intermedia. They had a terrible time. Somehow, with God's grace, ma'am, because I said, "So what? But this is such an important thing. आपको मैंने आपकी history में आपसे पूछते हैं कि कोई baby was born with some mental defect." He said, "वो सब तो आपने पूछा था, मंद बुद्धि पूछा था, पर आपने हमसे ये नहीं पूछा था." So that is a lesson I learned कि आपने मंद बुद्धि पूछा था, आपने पेरेंट्स में डायबिटीज पूछी थी, पर आपने हमें ये सब नहीं पूछा था. तो but somehow, ma'am, they stuck with me. Then they had 2 terminations because I got a CVS done, thalassemia. Both the time it was major. Fortunately, then the 4th time when she conceived, normal pregnancy, and then of course, uska bone marrow transplant hua for the first baby. They're still with me, ma'am, but that was one lesson I would never like to repeat again. कि आपने पूछा नहीं तो इसलिए मैंने बताया नहीं. And my own mistake कि hemoglobin क्योंकि 11.5 था, I never dreamt that she'll have thalassemia. This is a mistake which all of us do. That just because hemoglobin is more than 10, you just don't suspect thalassemia. You're young and healthy, you will never have thalassemia. That is what even I thought. That was it, ma'am.
Now, here I just wish to tell you what Dr. J.S. Arora and Dr. Deepika Deka often say, that your hemoglobin may be absolutely all right, still you can be thalassemia minor. So I think, unless you get the testing done, you will not know whether you are.
Yes, yes.
Lena, you want to share some of your experience?
That same case which I mentioned, and I've seen the couple after having given birth to a thalassemia major child and running from pillar to post, blood transfusions, hospitals, in and out, and finally a ray of hope. They managed to get a donor and a bone marrow transplant, and after that they spent a good 5 years of their life just doing that, and the lady was so petrified of even planning a second pregnancy. It was that, and it was just because they hadn't been screened. They hadn't been screened for thalassemia minor, so nobody knew that till they actually gave birth. She gave birth to a thalassemia major. So I think it's very traumatic, like you mentioned in your slide about the fear, the guilt, and the kind of the counseling and the kind of environment that we are living in. So it's so very important. And this second baby, when I was the gynecologist, I remember every time she would say, even after the CVS was done, "I hope they are sure." She would keep saying, "I hope they are sure," because she had gone through such a traumatic experience. And thankfully, there was a nice end to the story. So, she had a healthy baby, but it's not so with so many other people, like you just mentioned. So they owe it to us to screen all and each one of our pregnant patients. And another thing I would like to just add, that it doesn't matter the gravida of a patient. Many times they've had a previous pregnancy, and the thinking is this is a second gravida, so why to get all these tests done? No, each and every pregnancy we need to check, because we don't know whether they have got it done or not. Most patients are not aware whether they have got this thalassemia screen done in the previous pregnancy. So let's do it for each and every pregnant patient who comes to us.
Now here I differ with you, Leena. My patient always keep their record and they will bring always this thing, madam, you got it done. So we have also become very sure that 100% we've got a screen done. But I think today we thank Madam Arpita to give this particular platform, because this is one of the largest platform of doctors, and many people who are non-medicals are listening us. And Leena yourself and yes.
Sorry to interrupt. There is one more query, if you can answer.
Yes, we can answer.
Ma'am, how to go about an HbA2 of 3.7% and the lab report showing a normal range till 3.7?
See, anything more than 3.5 is suspected to have thalassemia minor. And I think, retest can be done from the same lab, and that will be great. That will be great. And here I just wish to thank my experts, Dr. Deepti Nab, as well as Dr. Leena Shirdhar and Arpita, to you for giving this platform, because Thalassemia mission is a big mission. If Delhi cannot screen 70% of the pregnant ladies, what will happen to the rest of the country? So Delhi should be trendsetter, and simple message which we want to do it: every pregnant patient must be screened for thalassemia. Thank you very much.
Thank you so much. I would like to, yes, ma'am, extend my heartfelt gratitude to Dr. Jain, Dr. Sridhar, ma'am, and Dr. Deepti Nab, ma'am, for sharing the valuable insights in today's session. It was such an important one. Thank you, all of you, for your time, your dedication, and the work that you do for women health. So thank you once again. Thank you for your time and effort. Thank you.
And I apologize. I apologize for not presenting myself. So the slide were not updated. But I think that did the job. Thank you very much.
No issue, ma'am. No issue with that. Thank you so much. Thank you everyone for joining.